Hello, everybody. Today we are going to talk about fall prevention. So, a fall is a never event, which means to say that no patient should ever fall in a hospital setting. But for you who have been in nursing care for a long period of time, you know that even with the best nursing care, sometimes our patients do fall. So all of our patients that go through our hospital setting, go through the ED or the OB or any portal of entry to the hospital, undergo what you call a fall risk assessment. Whether it's a peds patient or an adults patient, the goal remains the same. It's to come up with a certain score. So a score for the adult population that's 14 and above puts a patient at a high risk for falls. So according to our policy, a fall is defined as any unplanned descent to the floor, whether it's aided or unaided, and whether it has an injury or no injury at all. So therefore, what are the things that we do in order to prevent our patients from falling? All right, so we go back to the basics. Number one, we talk about side rails. So how many side rails should be up? Yep, you are right. We need to have 3 side rails up. Why not 4? When we put all 4 side rails up, it means that we are putting our patients on a restraint, and therefore you need an order for that. So 3 side rails up. What else do? We declutter the room. We make sure that the cords are put to the side. We make sure that the floor is dry. Make sure that the room is well lighted, especially during the day. And then one very important thing that we always do as healthcare practitioners is what we call your purposeful rounding. Okay, with purposeful rounding, it brings us to the 4 P's. And what are these 4 P's? The first P is pain. Okay, so what is number 1 goal for pain? We all know that the number 1 goal for pain is to manage pain, or if you can eliminate pain, then eliminate pain. One of the major interventions so that we achieve that goal is to put our patient on pain medications. We all know that the number 1 side effect to pain medication, among other things, is drowsiness, dizziness, and unaltered levels of consciousness. When our patients feel dizzy, they feel drowsy, or they are in a state of altered levels of consciousness, they are then most likely to fall. So this is the main reason why our patients on pain medications or who are in pain would most likely to fall. Now, do our patients know this? Unfortunately, they don't. They think that that simple pill that you're giving them to alleviate their pain is actually the solution to their main problem, not knowing that that solution to their main problem may become the reason why they will undergo one of the most common complications of hospitalization, which is falling. Therefore, as nurses, anesthetists, and as healthcare providers, it is our responsibility to provide our patient with a proper education for the side effects of pain medications and anything associated to pain management. The second P is what we call position. More often than not, it's our obligation or responsibility to do position changes, okay? And to provide mobility, to assist in ambulation. So even with the most self-sufficient and independent patients, we would want mobility, ambulation, and position changes to be as supervised as possible. Therefore, we are preventing our patients from falling. The third P is on possession. This is something that we do every day. With possession, we make sure that anything that's near and dear to our patient's heart are placed near them, whether it's the call bell, whether it's a cup of water, whether it's their personal possessions like their bag, their books, or their wallet, a picture of their loved one, anything that you can think of that you think is important to our patients need to be within their reach. That way they don't have to get up, they don't have to reach for these things, and maybe subsequently fall. The last of the 4 P's that is very essential to our purposeful rounding is what we call putty or toileting. Now, according to research and evidence, putty or toileting is the number 1 reason why our patients fall in the hospital setting. I would like to repeat that. Putty and toileting is the number 1 reason why our patients fall in a hospital setting. Now, when you check on your patients and you do your rounds, what is that number 1 question that you usually ask your patients? Isn't it that you ask your patients, do you want to go to the bathroom? And that what? How does your patient respond? More often than not, your patient would say, no, they don't feel like going, or they don't have the urge, or they just came out of the bathroom about 5 minutes ago. But then when you leave, or 2 minutes after you leave, what usually happens? The call bell starts ringing, or they start calling you. Now, are you fast enough to come back to the room to their rescue so that you are able to help them to the bathroom? More often than not, no. You may be in another room supervising another patient, or your walk from the nurse's station down to your patient's room may take about 2 minutes, but to your patient, it's about equivalent to 2 hours. So here they are, they would say, you know what? I've been going to the bathroom for the past how many years of my life, and so I am going to the bathroom myself. But then, in the past many years of their life, there was no SCD attached to them, there is no IV attached to them, they forget about this, they trip, they fall. So then that's a reason why probably toileting is the number one reason why patients fall in the hospital setting. So we are not asking our patients to go to the bathroom anymore. We are telling them it is toileting at our own terms as healthcare providers. So the next time you go check on your patient and you do your purposeful rounding, do not ask them to go to the bathroom. You are actually telling them that they are going to the bathroom with you, or that is what we call supervised toileting. So now I say, hey sir, my name is Renilda. I am here, let's go to the bathroom. Chances are they might still say, oh no, I don't feel like going, or I don't have the urge. But you are the type of nurse who does not take no for an answer. And so you say, I am already here. You just have to try. Let's go to the bathroom together. And if you're not able to go, then I'll come back later. But since I'm already here, I am going to bring you to the bathroom. Chances are, more often than not, they're able to go. So what does this practice enable? What does this practice promote? There are two things. Number one, it establishes a sense of routine that every time you come and visit your patient, he will expect you to, or he or she will expect you to bring you to the bathroom, to bring a patient to the bathroom. And second, it establishes a sense of trust and confidence that you are true to your word. Well, for this to work, you have to really be true to your word. If you promised your patient that you are going to be back in an hour, then you or your designee need to be back. Because if you're not, then this strategy will never work. So, if we go back to the premise that most hospital falls are because of toileting or potty or going to the bathroom, if we establish toileting at our own terms and we establish a certain routine as to going to the bathroom, chances are our fall rates will go down. So now that we have finished talking about purposeful rounding, let us talk about alarms. So there are two common alarms that we establish here at our hospital setting that will help, that we activate in order to help our patients from falling. All right. So the first one is what you call your bed alarm. So before we even go through the process of how to set up your bed alarm, there are three things, bed basics. I call them kindergarten bed basics because they are pretty simple. So number one, we want that bed to be plugged all the time. Now, oftentimes I hear, no, it has been plugged for 22 hours or 20 hours, but then here you are seeing it unplugged. So there are two main reasons why our beds do not work. Number one, of course, user error. Nobody knows how to manipulate the bed and all that. But the second most common thing why our bed does not work is because it was not plugged. So do yourself a favor, always make sure that your bed is plugged. Very simple. Number two, the other cable that I want you guys to get plugged all the time is this white thing at the back of the bed. All right. So most of our units have an adapter on the wall that corresponds to this. So what does this cable do? It does not just enable you to hear the alarm, but it also tells you which specific bed is alarming. Chances are, if you put the alarm of the bed volume up, you can actually hear the bed alarming. But if you belong to a larger unit, chances are by the time you decipher which bed is alarming, your patient's already on the floor. So again, do yourselves a favor, plug this white cable into that adapter on the wall. And the third thing that I want you guys to always do as a habit, which unfortunately not many nurses do, is to zero the bed. Okay, zero the bed. Now, how do you zero the bed? There are certain steps, and we have another video that actually refers to the specifics of how to zero the bed. So I'm going to just discuss it very briefly. So before you transfer your patient from the patient's stretcher to the actual patient bed, make sure that the bed is made. Make sure that the most important or common components of your bed are there. For example, a patient's pillow or the call bell, for instance. So once you've done that, on the side rail, on this side rail here, on the bottom portion, there are these buttons that I'm going to show to you. So there's this button here. So this button here that says zero the bed. Hit that until it registers 0.0. Once you've done that, then you know that your bed has been zeroed. And this is the time when you transfer your patient from the stretcher to the bed. So since you're a very efficient nurse, you're very efficient, and you've done all three, you are now ready to set the sensitivity button. Okay? So there are 3 sensitivity buttons. The first button is the most sensitive. Now, we are not encouraging you to activate that all the time because it will pluck the last of your nerve. Your patient turns from side to side, they cough, they sneeze, they laugh. That will activate that. So you would be coming running for nothing at all. Unless, of course, your patient is probably from the OR and the order is for your patient to stay flat on their bed for 2 hours, then that's the only reason. It's one of the most common reasons that you set the first sensitivity alarm. Okay, but other than that, you shouldn't be activating that. The third button here is also the least sensitive, so we don't also want you to activate that button. Your patient would already be up, already be on the floor before the patient alarm, so it's way too late. Okay, so we are therefore recommending that you hit the second button, the second sensitivity button. When you activate this button, your bed will alarm as a limb is off. So when an arm is off the bed or a leg is off, the alarm sounds. So it will give you an appropriate time to be able to come back to your patient and say, hey, what are you trying to do? I told you to call me if you need something. So do you need something? Therefore, preventing our patients from falling. All right, so that's the bed alarm. The second alarm that I am going to talk about today is your chair alarm. So it's composed of 2 parts. You have a disposable component and you have a non-disposable component. It is a very simple machine. It works like a telephone cord. So you plug this in. You make sure that the toggle switch here is on the on or reset button, and you're actually good to go. So let's talk about the disposable component first. So the disposable component or the chair pad is good for 30 days. So when you initiate this, make sure you put the start date. Okay, now do I think that it will work on the 31st day? Chances are it will still work on the 31st day, but we all err on the side of safety. So on the 31st day, make sure you get a new chair pad. Okay, so when you open the packaging, it comes with an anti-slip device. Of course, you put that on the chair. You put the chair pad over the anti-slip device. You may cover this with an egg crate or a waffle cushion or anything to make your patient comfortable. You put a certain degree of weight or pressure. This machine will chirp 2 or 3 times and you're good to go. Okay, so that's how simple it is. Now, I just want you to remember a few things about your chair alarm or chair pad rather. So number 1, it has a very long cord. You don't want this to be the reason why you will trip as a provider or your patient will trip. So you make sure that it's stuck to the side, not within the reach of your patient or not in the way of your patient. And then the other thing is that this, of course, emits a very loud, obnoxious sound. So it would be your patients would really quickly learn how to unplug this and how to reset the button here. So you make sure that this is not also within the reach of your patients. All right. So both your bed alarm and your chair alarm, again, they are independent nursing functions, and therefore you do not need a physician's order in order to initiate them. But take pride and take ownership and pride in the things that you do for the safety of your patients. Make sure that you document them under patient safety.